Good evening, everybody. My name is Lorna McGill, Lead Tissue Viability Nurse, and we are here to go through the Purpose T Pressure Ulcer Risk Assessment Tool. So I'm going to share my screen so that we can see where the resources are and how to access them on the intranet. So when we go to the home page of the intranet, we see T for tissue viability, and under that tab we have Purpose T resources housed here. There's a little bit of background about the Purpose T itself, and then our resources are at the bottom of the page. So firstly, we have the adult risk assessment, then we have pediatric and maternity with very slight variations. This box leads us to the Purpose T pathway, which is a very simplified form explaining the red, amber and green pathways and also denoting the categorization of pressure ulcers. So this may be something you want to print and use as a poster within your clinical areas. We have training dates advertised here running throughout October, and there is a hybrid of face-to-face sessions and webinars which people can access. This box leads us to the National Health Service England e-learning for health resources. So they have several modules on the Purpose T where you can work through scenarios. And at the very bottom of the page is where the standard operating procedure will be linked as soon as that has been ratified. It's been through policy and procedure group, so should be up within the next few weeks, I anticipate. Here we have the Purpose T introduction, the PowerPoint presentation, which we're now going to work through. So that is there for you that you can use for teaching locally within your areas, or indeed just as a resource to refer back to. So why is it called the Purpose T? It is simply an acronym for Pressure Ulcer Risk, Primary or Secondary Evaluation Tool. The Purpose T was developed in the University of Leeds, and it has been based on very high-level, robust, systematic review evidence. It has been recommended for use throughout the National Health Service in England and also by the National Wound Care Strategy Programme. I will refer again to the National Wound Care Strategy Programme when we talk about the categorisation of pressure ulcers. The Purpose T will replace the Waterloo score throughout UHD on the 28th of October. And we are going to start initially on hard copy, pen and paper versions for a period of around 4 weeks before we move to the ENA application. The reasoning for that is when we're familiar with the tool and the colour coding system and the simplicity of it on pen and paper, the transition over to the ENA version will be fairly intuitive. So the benefits of the Purpose T. It provides screening for all patients and will quickly screen out those patients that are not at risk of pressure damage. The Purpose T will save time in clinical practice because it is evaluated weekly on any change in the patient's condition or on transfer between wards. So when we compare that to the Waterloo score, which we re-evaluated every 24, 48 or 72 hours, we can see an immediate time saving, that we're doing away with that unnecessary repetition if there has been no change in the patient's clinical condition. Purpose T has been validated in adults, paediatrics and maternity, so can be used across these populations. And it includes a visual check of the skin. So what is their pressure ulcer status at this moment in time? It supports care planning for preventative care. and it's nicely color-coded, which helps us in our decision-making process. It also makes a clear distinction between those who require primary prevention, so they're at risk of pressure damage, but they don't have any pressure areas, and secondary and prevention and treatment pathway, where the patient already has pressure damage or scarring from a previous pressure ulcer, and we also need to prevent further damage occurring. For those of you that have not yet had the opportunity to see the Purpose T, this is what it looks like. It is photocopied, double-sided colour, so one assessment on the front of the page, and then when the reassessment is due, that will be on the back of the sheet. So for 2 minutes, I just want us to look at it at its very overarching level for simplicity, and we will then work through each of the steps in detail. So we can see here we have step 1. We screen all of our patients. Blue boxes indicate no problems, normal skin, and no risk factors identified. So you would immediately screen that patient out and they would be on a green pathway. For the majority of us, our patients in our care will have some risk factors or triggers. If we're ticking a yellow box, we are then moving right down to complete our full assessment. The full assessment mirrors all of the risk factors that you're already familiar with from your Waterloo risk assessment, but it also includes a detailed skin assessment of all the pressure points. Once we have step 2 completed, depending on the colour of boxes that we have ticked, our patients will either be on a green pathway, an amber pathway, or a red pathway. So the initial step 1, screening for all patients. The first box here relates to the mobility status of our patient. A blue box means that they're up and about independently with or without walking aids, so there are no concerns. You will see, however, that all of the yellow boxes indicate that there's something there that we need to explore a little bit further. It may be that they need the help of another person to walk, that they spend all or the majority of time in bed or a chair, or that they remain in the same position for long periods. If we are ticking any of the yellow boxes, we immediately move down to complete step 2. There's no need to continue along the horizontal. The second box relates to skin status. Again, blue, normal skin, no problems noted. Yellow category, if the patient has a reported history of previous pressure damage. If the patient has vulnerable skin over their bony prominences, or if there's a medical device in situ causing pressure or shear at the skin site. You will see here that we have one red box or pink box, which is telling us that the patient has a current pressure ulcer present, category 1 or above. If any yellow or pink boxes are ticked, we move down to complete our full assessment. While the Purpose T pressure ulcer risk assessment tool is based on very robust evidence, it does not negate the need for the use of our clinical judgment. And there are 2 main triggers as we work through the tool where we're reminded of the importance of our clinical judgment. So here we think of patients who may have a condition or of undergoing treatments which would significantly impact their pressure ulcer risk. That may be something like poor perfusion, an epidural, a lot of edema, or steroids. Any of those risk factors would give us a yellow box and we would proceed to the full assessment. So throughout step 1, if any of the yellow or the one pink box has been ticked, we move directly to step 2, the full assessment. Step 2 includes all of the risk factors which you will already be familiar with, And you'll note here that we've included medical devices and our skin assessment. So we'll work through each of these in a little bit more detail. So first off, mobility level is the most important factor. So we think of our patient's ability to move independently. If they can move frequently with major position changes, we are ticking a yellow box. If their mobility is more restricted than that, we are then moving into the orange boxes. So it may be that they don't move at all or they're making only very slight position changes. That would put them immediately at risk with an orange box ticked. We then think of sensory perception and response. A blue box if there's no problem or concern, and straight away they go to an orange box if they are unable to feel or respond appropriately to discomfort from pressure. So it may be a stroke, neuropathy, an epidural in situ immediately puts our patient at risk. Moisture. This category is nicely worded because it reminds us that moisture may be due to perspiration or exudate. It is not always simply from urine or feces. We have a blue box if there is no problem or very occasional, and a yellow box if there are frequent or constant concerns about increased moisture. People have asked about the subjectivity between these two boxes of frequent and constant. If the patient has just been admitted to your ward, you may not know the absolute correct answer to this as yet. However, they both just give us a yellow box indicating that we need to consider it a little bit further. Next, we have diabetes. A blue box if the patient is not diabetic, not increasing their risk, and a yellow box if the patient is diabetic. People have asked how we categorize pre-diabetes. So on the electronic version, I have added a little line here just to say if the patient is pre-diabetic, they are not diabetic, just to be nice and clear for everyone completing it. With regard to perfusion, a blue box if there is no problem of concern at all. And you will see here that they get an orange box if they have conditions affecting their central circulation, shock, heart failure, hypertension, and an orange box if they have conditions affecting their peripheral circulation, such as peripheral vascular disease. If your patient is nursed in intensive care, perhaps on inotropes, suffering shock and low blood pressure, but they also have a history of peripheral vascular disease, we are still giving them orange boxes indicating that they are at risk of pressure damage. Our next category then is nutrition. A blue box if there's no problem regarding this, and each of these are a yellow box for unplanned weight loss, poor nutritional intake, or a low or high BMI. We then have medical devices. Blue if there's no problem, no devices in situ, and a yellow box if we have a medical device which is causing pressure or shear at the skin site. This could be anything from plaster casts to urinary catheters. The examples included here are oxygen masks and NG tubes, but think of all of the many devices which we place on our patients when they are admitted into our care. Moving on then to the categorization of pressure damage. We will all be familiar with category 1, 2, 3 and 4. Unstageable also where we're unable to see the depth of the wound base. I just at this stage want to allude to a couple of changes which have come down from the National Wound Care Strategy Programme. But first of all, just to make it clear that clinically at ward level, there are no imminent changes to how we document and categorise pressure ulcers. If you're a sister or a matron, however, you will probably already be aware that if there is an unstageable pressure ulcer reported from your area, I, during the validation process, will amend that to Category 3 pressure damage. The logic behind that is that we know that all unstageable pressure ulcers are of at least Category 3. If they then evolve into Category 4 damage, the day text can be amended at a later date. But at least with this system, we are ensuring that all are counted in our numbers and in our pressure ulcer reports every month. The other change which you may notice here is that DTI is not included in your key for categorization. And when we look at our next section of the detailed skin assessment, we will say that deep tissue injuries are included as vulnerable skin. The rationale behind that is that the majority of DTIs which are reported on Daytex resolve themselves, usually within a number of weeks. So therefore will be counted as vulnerable skin. However, if they evolve into a Category 3 or 4 pressure ulcer, then they will of course be referred to as such within our Purpose T and Daytex systems. I have included a little note here to remind us that moisture-associated skin damage is very different from a pressure ulcer, but it will increase the patient's risk of pressure damage. So if we have ticked any orange boxes, but nothing pink, the patient will be on an amber pathway. If only yellow boxes are ticked, we need to think and use our clinical judgment and make that decision whether it's an amber or a green pathway. Our current detailed skin assessment maintains the same colour scheme. So we have blue boxes if the skin is normal and there's no problem or concern. We have a yellow box if the patient's reporting pain over that bony prominence or area. We have an orange box if there's a DTI present or the patient has very vulnerable skin over the bony prominence. And we have a pink box if there is pressure damage present of Category 1 or above. With regard to the electronic version of the tool, rather than having to tick each individual box, there will be a one box ticks all option, which will tick all of your body sites as blue for normal skin. And you then will be able to go in and amend to say, oh, I've got a DTI on my sacrum, so you're going to tick an orange box for that particular body part. Also to mention about below knee or above knee amputations. So on the paper version, it's quite easy to draw a line through the left heel and left ankle, for example. However, when we are using this on ENA, each of these fields are mandated and we must tick a box. So the only logical workaround for that is if the patient has had a left below knee amputation, we tick the blue box for normal skin for the left heel and left ankle, alluding to the fact that those areas are not impacting on that individual patient's pressure ulcer risk. It'll obviously be documented elsewhere that the amputation has occurred. There is some free text space where we can add other areas which may develop pressure damage, ears, noses, anywhere else that damage may occur with the same colour coding. We then think of a previous history of pressure damage. If there's no known pressure ulcer history, we have a blue box, it's not a problem. And if we know they have had pressure damage in the past, that is a yellow box, leading us to fill in the details below. Now, if we know the approximate date, and we mean approximate. So was it 2 weeks ago or was it 5 years ago? Just very approximate with regard to that. If we know the site of the damage, include it here. If we know the category, we can put it here. And if we see scar tissue present, that would indicate that the damage was of category 3 or category 4, so they're getting a red box. If there's no scar tissue present, that will be a blue box because that would indicate that the damage was most likely of category 1 or category 2. There is a free text box where we can add any additional information if it is pertinent. Throughout this, if any pink boxes are ticked, your patient has pressure damage present or scarring from a previous pressure ulcer, and they will go on to the red pathway, which is our secondary prevention and treatment pathway. If orange boxes are ticked but no pink, our patient has risk factors and perhaps a DTI or vulnerable skin, they will go on to the amber pathway, which is our primary prevention pathway. So step 3 at the bottom of our purpose T is our assessment decision. So if any pink boxes are ticked, we're coming down this line and going on to a red pathway. If any orange boxes are ticked, they have no pressure ulcer, onto an amber pathway. But the second place where I mentioned about clinical judgment needing to be employed is here. If only yellow and blue boxes are ticked, we need to consider the risk profile of that individual to decide whether or not they are currently at risk. So just to put that into context, I'm a 75-year-old lady. I am extremely thin and report very poor appetite recently. I have a history of diabetes and I'm occasionally incontinent. However, I am completely cognitively aware, independent, self-caring, and up and about. So you will make the decision that although we have ticked some yellow boxes with regard to my nutrition, my continence, and my diabetes, I'm up and about independently, and you will place me on a green pathway because there's nothing additional you need to do for my pressure ulcer risk. However, same case scenario, and I'm admitted to your ward with abdominal pain, I'm very lethargic, I'm not really interacting. You just think if you don't place me onto an amber pathway, there's a chance that I may just sit about in the chair all day or lie in the bed all day, and you need to ensure that I am on a pressure ulcer pathway with a skin bundle to reduce my risk of damage happening. So what do these pathways look like? Our green pathway indicates that there is no pressure ulcer present and the patient is not currently at risk of damage. We reassess weekly on any change in the patient's condition or on transfer between wards. The words in this box remain the same whatever colour the pathway the patient is on. So an amber pathway then. No pressure ulcer, but the patient is at risk. So we need to start our patient on a personalised or individualised plan of preventative care. That will include all of the elements of your skin bundle, which you will all be familiar with in whatever format that currently takes within your ward area. There are various different tools around involving a paper skin bundle and a repositioning chart or a 7-day booklet. For now, continue to use whatever is local practice within your area. However, my goal is, come the springtime, to amalgamate the skin bundle into a UHD bundle, which will be available throughout the trust and therefore make it easier for staff to complete if they're working across different areas. You will see here that I've included the A for assessing the risk. We did that anyway with the Waterloo, and we will now be moving forward using our purpose T. And the only other addition is the G for giving information to remind us of the importance of providing our patients with a pressure ulcer prevention leaflet, information and education on what we are trying to do and what they themselves can do to reduce their risk of acquiring pressure damage. You will see here that the words within the box regarding reassessment have not changed weekly, on any change in the patient's condition, or on transfer between wards. The red pathway then includes patients who have a category 1 or scarring, or an actual pressure ulcer present at the moment. So I've split this into two sections. If we've got category 1 or scarring, we need to implement that personalised, individualised plan of preventative care, and we need to reassess our risk weekly on any change in the patient's condition or on transfer between wards. If, however, there is a pressure ulcer present of category 2, 3 or 4, in addition to the skin bundle and the reassessment plan, we would need to commence a wound assessment chart detailing the wound as it is at the moment and the plan of care for that. We would need to submit a Datex, consider photography, and if the damage is of category 3 or 4, also a tissue viability nurse referral. I've included what I anticipate our UHD skin bundle will look like with the addition of the A for the assessment as alluding to the purpose T and reminding us of our safeguarding if required, and the G for the giving of information where we need to provide an information leaflet, consider the capacity of the patient and think about those patients who are declining care. Do they have the capacity to understand what we are trying to do to help and support them? And if they are continuing to decline pro-offered care, then the need to document and escalate those concerns. I have also included this body showing the common sites for pressure ulcer development. We see here that our sacral and buttocks area is the most common area within UHD and indeed within all of the research papers. However, it is very closely followed by heels. They can be quite easily offloaded, so in a lot of patients, maybe not all, so it is of paramount importance to be paying attention to those patients at risk and getting those heels offloaded and documented that we have provided method for offloading the heels to reduce risk. This slide just runs through the categorization of pressure damage. So category 1, where we have an area of non-blanching erythema, but it is intact skin over a bony prominence. Category 2 damage can present as a clear fluid-filled blister, or if that superficial layer of epidermis was removed, it would be a very superficial pink wound with no slough, no discoloration. With category 3 damage, we have full thickness damage and there may well be some depth evident to that wound or undermining present. With category 3, we are not down to underlying structures such as muscle, tendon or bone. And unfortunately, we are all familiar with what a category 4 pressure ulcer presents as, where we have full thickness skin loss, and we are right down to the underlying structures being exposed, such as fascia, muscle, tendon, bone. When we have exposed bone, we are at a very increased risk of development of osteomyelitis. This slide is just a reminder about the importance of considering the etiology of damage. So moisture-associated skin damage would be a common differential between category 3 pressure ulcers. So I've included a couple of photographs to remind us that MASD will occur within skin folds and is frequently seen in the natal cleft. And it is always linear or mirror image, irregular in presentation. So if we have a little fine line in the crease of the buttocks, it is always due to moisture and not pressure. Then we think of a butterfly with a mirror image presentation, and wounds such as this, not focused over the bony prominence, irregularly shaped, always due to moisture, not pressure. Pressure damage, on the other hand, occurs over a bony prominence or under a device and is caused by pressure with or without shear. And we can see the difference here that pressure damage tends to be a regular shape focused over the bony prominence, in this case the heel, and here over the sacral area. So training resources available. As you will hopefully know, we've been running and continue to run a few face-to-face sessions, and there are a selection of webinars available advertised on the intranet, which people can apply to attend and log in and join online. I've shown you at the very beginning where our Purpose T resources are available on the intranet, and that is where the SOP will be published when that is ready to go. The electronic version of the ENA is anticipated to be ready to go live towards the end of November, and those dates will be published and shared nearer the time when that is confirmed. And this is just a reminder of the e-learning for health, where you can work through some case scenarios and actually complete the Purpose T risk assessment tool to increase familiarity with the sections involved. So whenever the clocks go back, the following Monday, the 28th of October, our Waterloo will be switched off and we will commence use of the Purpose T. I just have two more slides to talk about. I have references and acknowledgements included here, and this leads us to the pressure ulcer categorization tool. If anybody wants to access that resource, the link is there. And the final two slides are just to show that the pediatric and maternity versions have very minimal differences between them. So the teaching and the training for all Purpose T is the same, and these slides show that the minor changes are in the pediatric version. They have included nappies and they refer to centile weights instead of BMIs. Pediatrics have not yet had the opportunity to develop peripheral arterial disease, and they have included ears as one of the skin sites because of the larger head size in the very small pediatric population. We, of course, can include ears on our additional sites listed. With regard to the maternity tool, they have narrowed the window for mobility to be between 2 to 3 hours. As you will know, if you're used caring for adults, we recommend 4 hourly position change in bed, 2 hourly when in a chair. However, due to the situation in maternity where a fully independent expectant mum may suddenly be epidural in situ, insensate, increased moisture and very high shearing forces during labour, their risk factors immediately are highly escalated, so that is why they have likely reduced that to a narrower window of 2 to 3 hours. They have included CTG belts, which relates to the fetal monitoring devices which may be used, and under moisture they have also included rupture of the membranes leading to increased moisture damage in that area. Thank you all very much for your attention. Hopefully that has been informative for you, and If you have any questions or queries, please do contact either myself, Lorna.McGill at UHD, or in some areas, your practice educators will be able to assist with any queries which you may have. Thank you all very much for your attention. Good night.